Hello, everyone, and welcome to today's webinar titled Navigate the Pandemic Through Laboratory Operational Excellence. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit them at abbott.com. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing this presentation, simply click on that Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of your presentation window and follow the process to obtain your credits. I now present today's speaker, Rouba Trad, a lab manager at Clemenceau Medical Center affiliated with Johns Hopkins Medicine International. For a complete biography of our speaker, please visit the Biography tab at the top of your screen. Rouba, welcome. You may now begin your presentation.
Okay. Thank you, Bridge, for this introduction. I'm really excited to be here and to share my experience, and thank you for joining me in this webinar. I had the opportunity to join Clemenceau Medical Center 15 years ago when it started its operation. I had designed and commissioned it in Beirut and did the same as well with our sister hospitals in the Gulf area. My main focus was on laboratory automation, which we worked at really extensively, and I had the opportunity to launch the first lab automation system in Beirut, Lebanon, and supported the same in our two sister hospitals in Dubai and Riyadh. All right. Today's talk is about navigating the pandemic through laboratory operational excellence. As a start, to tell you that this information is based on my own laboratory experience, and the allocate series is not currently available in all countries, including the United States. Furthermore, I would like to recognize the effort of one holistic multidisciplinary team that included the lab, the engineering, and the IT team under the support and supervision of my lab director, Dr. Ziad Baba. The whole team, from the senior quality officers to coordinators and the lab technologists, they worked holistically in order to ensure continuous improvement initiatives. Our talk today will be, first of all, introducing our medical center, and we'll talk a bit about our project and how we have worked on implementing it. Then we'll go thoroughly into some solution benefits and how it had an impact on our operation. And then we will share with you the outcomes of the study that we have collected some data and analyzed to support these operational excellence initiatives. And we will share with you at the end what we have done during the COVID-19 pandemic and how this laboratory automation has helped us to go through and still going on till today. As an introduction, Clemenceau Medical Center is a medical center located in the center of Beirut, Lebanon. A 158-bed hospital with 11 OR and 40 clinics. Our mission and vision is to provide the state-of-the-art technology to our patients in Lebanon and in the region. And we have created certain centers of excellence in certain areas, including radiotherapy and robotic surgery. We are affiliated with Johns Hopkins Medicine International, and we are GCI accredited, and our latest award was the 2019 MTQA for the best hospital for medical tourism. And yet we are striving for more in the future. As far as our lab overview, as you can see, our volume is around 500,000 tests per year. It we have transitioned from the legacy systems of Beckman to all Alinity aids. Our main challenges in the lab, in the core lab project, mainly was budget constraints, limited space, which we'll talk deeply later on, and as well as increased demand due to hospital expansion, especially during, especially for medical tourism, as well as during COVID-19 pandemic. If we check the lab layout, before, as you can see, it was a very traditional laboratory, starting with having several benches, separating each section from it, and not really connected. If you can see, if we go from the right to the left, we had the blood gas and receiving area. Then we go through the hematology and coagulation section. The second bench was mainly for immunology and serology, reaching at the end to the chemistry. What we have discussed with the Abbott team is to have more like a streamlined process and to decrease the non-added value of steps for staff. And we ended up of having a core lab almost in the middle, where all these systems and components have been integrated, bringing much more space to the lab and leaving all the benches at the sides for other specialized tests such as autoimmune allergy testing, as well as for manual testing. And this has given us much more space if you want to have future expansion. It's worth noting that the space of the lab is around 120 meters square. Now, why we have chosen Abbott? It aligned with our strategic goals in terms of introducing new services that are evidence-based and thus controlling costs. But most importantly, it helped us in our regional expansion. As you know, CMC is expanding in the Gulf area. We already have two sister hospitals, one in Dubai and one in Riyadh, and we wanted one system that is able to be installed in all our hospitals, whereby our staff can work in the other institution while thus decreasing the time for training and staff development. This journey has started in February 2016, and it took us around 2 years to finalize the project. It was initiated in December 2019, and we went live almost by May 2019, covering all laboratory automation components. It is worth noting that the study that we're going to discuss later is between May 2019 and August 2019 phase. It is very important to say that the Abbott team really helped us transition from the legacy to Alinity in a very smooth way and very efficient way. We were able to, from the installation in December to go live maximum by May, finalizing all engineering, IT, as well as quality studies. We are also, as CMC, committed for continuous improvement and finding new opportunities to improve efficiencies, and that is why currently we are in phase 2 of the study after following that the Alinity H went live, and we are starting to plan and design for the phase 3 in 2021, which will include the installation and the implementation of MIQ risk stratification software. Now we have evaluated the lab automation project by creating an objective matrix that is referred into 4 components that are very crucial and important, mainly lab, engineering, financial, and information. Each one has a certain emphasis, thus covering all these aspects into 15 indicators. And out of these 15 indicators, Abbott has covered almost 14 as compared to the other brands in the market. Now, if we go Next, if we go to our solution benefit, the solution benefits mainly we're going to highlight the most important aspects that has an impact on our daily operation, on our quality of results when we want to compare the legacy instruments versus Alinity and what had impact on our patients' results. First of all, we have to emphasize on the Alinity uniformity in terms of chemistry, immunoassays, and hematology. The user interface was very helpful, and we have seen its impact in our training of staff. Our staff very, how we say, we're very comfortable to move from one analyzer to another, and that's what made us to change our recruitment strategy. Previously, with our legacy, we always recruited staff with having more experience because they were most of the time releasing results based on their critical thinking as well as their experience. Now, with the Abbott Lab automation components, we are more confident to recruit fresh graduates, and we are really confident that they will safely release patient results, and we were going to have and their training period has been decreased like any technologist having more than 3 years of experience. Since we implemented this project in May 2019 till today, we have around 70% of our core lab staff performed the cross-training in all sections, and this will provide us some mobility and flexibility to ensure rostering and coverage of the operation. The second important benefit is the assay performance. We have also observed that we have an increase in assay linearity affecting the decrease in the dilutions and the rerun, mainly as you can see in hepatic enzymes, reaching up to 8,000 like in gamma GT. And it has improved our turnaround time. The calibration frequency also has decreased by 57% in most assays, especially like in BUN, and that we used to do daily calibration. Now we're doing it almost on weekly basis, as well as like protein. We're doing it currently on a monthly basis rather than doing it on daily basis. And the total manual staff time saved by then was around 146 hours. The third point that we like to highlight is the ICT module, which is by itself a revolutionary technology. As you all know, electrolyte is a very tedious, it's very important also analyte. We have faced with our previous analyzers problems with maintenance, preventive maintenance, water quality, issues with the electrodes, as well as the probes that we had to continuously change them. And now with the ICT module, we are able to have stable and accurate results. The fourth issue is the overall automation benefit. The automation benefit in terms of the track that had an added value for Abbott is the open connectivity. The track, when we have decided in 2016, we had a list of around 26 non-Abbott analyzers that can be connected to the track, including flow cytometry, molecular, as well as urine analysis. That made us to look for opportunities to expand our menu, thus without the need of an additional technologist or expertise. The scalability of instruments is very interesting and very important when you need to add up more instruments, having a limited space, and this will give us business opportunities to expand our workload. I would like to highlight on the introduction of the quantitative HIL index. Once we have introduced it, it has saved a lot of time and helped us also to identify certain increase in results due to high hemolysis or high icteracy rate, and sometimes at the micro level that usually were not detected by our technologists manually. This implementation has reduced the manual step by almost 77% and thus also eliminated manual errors. When it comes to workflow, we have introduced two major components that were not previously available. The first is the allocator, and the second one is the online storage. The allocator, we have built the allocator in order to perform allocating for samples that require outsourced testing, and it will do direct labeling, thus decreasing all pre-analytical errors, and also in terms of saving the volume, especially for pediatrics and elderly and patients with difficult veins. We have studied this aspect by looking at the number of chemistry tubes consumed in 2018 versus 2019, and there was almost a drop of 18%. Our previous practice was that we needed to collect 3 chemistry tubes per patient, 1 for chemistry, 1 for endocrinology and serology, and 1 for the outsourced testing, and now it has been reduced to 1. The second important component that has saved a lot of time for us is the storage module. The online storage module has a capacity of around 9,000 tubes. It allowed us to expand the sample stability from 2 hours to 7 days mainly for the chemistry analyzers and especially for the hepatic enzymes. It also allowed us ease to retrieve any sample when we have add-ons and from the requested by the patient, and this has increased also the physician and the patient satisfaction. The AMS middleware had various improvements at all levels, from test to sample management, reaching quality. The historical reports helped us to understand the current data that we have, and helped us also use those data in order to look for more ways of improvement, and we will share them with you shortly. One of the major issues that we never had it before, and currently we are able to have them, is the ability and the increased visibility and traceability for assays and analyzers when it comes to panic values from a patient care point of view, as well as when we as well as from a quality management overview when we wanted to look at recalls in any order to evaluate any reagent and its impact on the patient results that were reported back then. In the AMS middleware, I would like to highlight more on the auto-verification rule. One of the data analysis that we're using is the auto-verification rate, which is the percent of results that have been automatically released from the software, rather manually from the technologists, having passed the auto-verification rules as well as the delta check. And when we looked at the data between April and August 2020, we found that it is around 60.5%, which is acceptable having working in a hospital setup. It is very interesting to highlight that the AMS allows us to have rules that are really flexible. We are on daily basis working with our quality department and the IT in order to add up rules based on incidents, based on near misses that we might face on daily basis. And the system is very flexible, by which it will allow us to modify and implement these rules for the better and safety and outcome. One of an example which I can highlight is the HbA1c rule, by which if we had a mislabeling of the CBC tube into a chemistry label, that might happen by a nurse or by a lab tech, and because of the load they couldn't identify that this tube does not belong to the proper container. We had put a rule to make hold of any value of HbA1c more than 10% to eliminate this pre-analytical error or to look for possible analytical error, if any. Another issue that we worked on, and it saved us a lot of tests and time is the test hold. Whenever we have any failure in a quality control rule, whether random or systemic, the AMS will push the machine to hold the test and to stop patient testing until we solve the quality control discrepancy. The impact of the auto-verification rule is have seen in our modified result rate. By definition, the modified result rate is any result that was reported to the physician and was modified based on pre-analytical, post-analytical, or post-analytical error. We had an increase in the rate in 2018 when we were manually entering with the results, and because of the high load of the volume that we had back then, with the limited number of technologists that we have, we ended up having many results that are ended empty. Sometimes we were misreporting those cases because of the manual practices. And when we introduced AMS software, this rate have decreased by less than 0.02, which is in the core lab, thus providing a better outcome. When we look at the outcomes, we have designed the study to look at various aspects of the importance of this automation to our lab. We started first of all with the space utilization. As you recall, our lab space is around 120 meters square, and with the new design and the introduction of the alinity in terms of space and throughput, our theoretical throughput have increased by 33%, and our tests per square meter have increased by 200%. Maintenance time. The maintenance time has decreased in total by 18% if you want to compare the legacy versus alinity. However, there was an 87% reduction in the manual maintenance time. So all those manual steps have been eliminated and become automated. That is why the impact on time was only by 18%. Because of this major finding, we have shifted those weekly maintenance activities during weekends shifts where we have less traffic during the lab, and also we have pushed our staff that were working during the weekends to do other duties in other sections such as bacteriology and parasitology, so for more efficient use of resources. We looked at also at the total value of ownership in terms of quality control consumption. We currently use the Biography as a third-party quality control, and we have seen a 50% reduction in the consumption versus 2018, and this has had a huge impact on our resources. This is mainly to the low dead volume as well as the low aspiration volume of alinity. Another issue that was eliminated is the sample preparation. We used to do pre-treatment for the sample in HbA1c as well as pre-treatment of the reagent for TIBC. As you can see the steps, and those steps have been eliminated with the ready-to-use reagents in alinity, thus saving around 742 hours annually in tech time. For the pre-analytical steps, which is the steps that were handled from the time of sample receipt till the time the test was resulted and the sample was loaded, it is around 13 steps, and this 13 step has been decreased to only 3 steps in terms of reception, loading of tube, and final unload, thus providing a 77% improvement. All right. So all these improvements and all these outcomes so far has allowed us to look at the scheduling of the staff. Previously, we had a 9-hour shifts covering around 10 technologists per day shifts, for example. The day shifts has been almost reduced by 33% by changing our shifts into 12-hour shifts. for part. We had also other staff were allocated to other activities such as phlebotomy and quality management activities, and that led also to a 70% decrease in the overtime. The last important outcome that we looked at is the turnaround time, which is almost a major headache for all laboratories. We studied the turnaround time in 2018 versus 2019, and we saw there's a total of 53% decrease in turnaround time of 124 tests that are run on chemistry, serology, and endocrinology. The major improvement in the average is in the chemistry by 94%. The improvement in endocrinology and serology is almost 30% for the reason that we have only one LNT analyzer till now, until we, and the carbon cell capacity allowed us to prioritize which tests are more urgent other than that. That's why the impact is only 30%, and we're looking forward to have it more when we introduce the second alinity analyzers. And the testimonial of our ER director is very important. Their satisfaction is quite important for us for mainly our stat tests. When it comes to the pandemic, so the first thing we look at when it comes to automation, we think of volume, we think of efficiencies, we think of how can we increase our workload and to have an excellent business model. But when the COVID-19 pandemic started in March 2020, the lab automation was not seen as being a burden, but rather a reliever and a business saver, for instance, because it helped us to overcome. So in Lebanon, the situation started in March, and we had like around 3 lockdown, 1 complete and 2 partial, and currently in November we are having the 3rd lockdown. Our hospital decided not to admit any COVID-19 patients. We are only covering outpatient screening patients and handling certain patients in ER before being transferred. This provided more confidence to our community to come and to seek care for non-COVID diseases, and till now the workload has not really decreased. We have always increased demand. In order for the lab to cope with this new situation, we faced 3 major challenges: how we have to ensure our staff safety, how we have to ensure our business continuity, and how we have to have an uninterrupted supply chain. In terms of staff safety, we have decreased our day shifts from 6 people per day into 3 teams of 2 people each, in order to have different teams covering the laboratory 12 hours daily, and enabling us, in case one of the teams got exposed, then the operation will still be run efficiently. In terms of business continuity, we have eliminated certain administrative tasks for the technologists, and we made them only focus on preventive maintenance, on quality control, in order to ensure quality of results, and thus without affecting any turnaround time. And since we have partnered with a strong distributor, we work together to collaborate to ensure that we have proper inventory, having delays in the courier services with the lockdown of the airports and the delay in the production in certain products. On the other hand, these delays have been compensated by the reagent packaging, because Alinity's reagent package is around almost, for certain analytes are 1,000, other is around 4,000 tests. So as well as for endocrinology, it's around 200 tests. This would allow us to use to consume those tests with an extended time until we get our new shipment. In our previous legacy, we had only around 100 test package, which we might fall into a problem facing such a pandemic. So our take-home message is mainly focused on that the life evaluation criteria has proven to be a strong objective criteria that helped us to highlight and benefits that are very important to us and to evaluate and make decision upon, and yet those benefits have been translated into positive outcomes that were highlighted in our study. More also that SCMC has realized that improvement in both operational excellence and integrated clinical care is very important once we have implemented the Apple Total solution in Beirut, and that's why when we chose a strong partner, we have decided to standardize our system in our affiliate hospitals in the Gulf region. Finally, the gains that we are currently had when we implemented those operational efficiencies in CMC during the pandemic has increased the high level of patient care that we have aimed to and we are bound to provide in Lebanon. Thank you so much for listening, and I'm ready to hear all your questions.
Thank you, Rouba, for that informative presentation. We will now start the live Q&A portion of our webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. So it looks like, Rouba, we already have some great questions coming in from our audience member. What are your plans around risk stratification at Clemenceau Medical Center?
Thank you for this interesting question. As you all know, cardiovascular diseases is increasing, and it is a quite prominent in Lebanon and in the Middle East. So our cardiology department is really active, and we looked around to see how can we help our patients and physicians to identify the best source for risk for coronary diseases risk assessment. And when we partnered with Abbott, we have worked with them on a project of it's a new software called MIQ risk stratification. It is software that allowed us to identify the risk of having any myocardial infarction incident. We will be working on the implementation of the software in 2021, and we're going to run around a one-year study to evaluate it for our population, and we're so excited about it because it's going to provide us more insight about the potential risks and mainly its impact on age and gender, because we rarely are able to identify events in young people which are less than 40 years of age, and it is quite common in our region. Thank you.
Our next question from our audience members are, how did the laboratory manage the transition to ensure there were no disruption to service levels and patient care?
Well, this is a very important and strong question because it was a great challenge for us. We have really planned it with the Abbott team as well as with our engineering and IT department, who all of them played a major role to ensure that our 24/7 operation is uninterrupted and our turnaround time and patient care also is not affected. So what we have done, we've planned, as you all remember from the slide, our space is around 120 meters square. So we divided the area into four sections. And what we do that each time we moved all the analyzers in this section on a mobile unit. And we moved as well all the infrastructure, the water systems, the network, and everything. It was mobile. during that time, and the technologists would be running the samples, and at the same time, in parallel, the engineers and the IT would prepare the infrastructure as designed at the same time. So our concerns was during that period when we had two areas, one running and the other one being under construction, is to ensure the employee safety. So we had the opportunity to mobilize those analyzers without being affected in terms of quality and their performance, in a way ensuring that the employees are being safe and not being disrupted. This whole plan took around 30 days, 30 non-stop days, including weekends and weekdays. And during that time, the quality team in our lab was monitoring the incidents and the turnaround time. And I'm really happy to say that during this 30 days, we only had 3 ER samples delayed in reporting the turnaround time to rather than 60 minutes to 72 minutes maximum. But other than that, we've had a remarkable operation. Thank you.
And thank you so much, Rouba. And I want to thank our audience members for these great questions coming in. Our next question, in addition to reduction in staff time due to automation, have you seen a reduction in errors?
So, well, definitely, we have set several KPIs in order to identify and to monitor if the incidents as well as the reduction of those errors. Mainly, we checked the modified result rate in order to see a reduction major in clerical errors. We also have noticed that there was a decrease in the frequency of the random quality control failures, especially in endocrinology and hepatic enzymes. And this has to do with 2 major issues. One of them is the increased reagent stability as compared to the legacy analyzers, as well as the automated steps in the preventive maintenance procedures. And these automated steps had a major impact because previously we used to do them manually, and we had a repetitive increase in aspiration errors. When those preventive maintenance in terms of cleaning and washing the probes has been done automated, though the aspiration errors have decreased tremendously and thus affecting the quality control performance.
Thank you so much, Rouba. And we have time for one more question. With COVID cases beginning to increase across the globe, is there anything your laboratory is doing to prepare for the second wave differently than what's already been done?
The COVID-19 pandemic has pushed us always on alert and always trying to be prepared and try to foresee things. It's not always working, but we try as much as possible. So after we passed the first wave, currently we are in the second wave, yet we tried earlier in August and September to prepare for it and to learn from the first wave as much as possible. So what we did 3 major things. First of all, we screened our employees to check for past and current exposure to COVID-19. And accordingly, based on those results, we have modified our staff schedule from 3 teams to 2 teams, each team of 3 members rather than 2, because we have seen that there is an increased demand in our hospital, especially in the ER, and we need to be able to handle those increase in workload efficiently by ensuring as well our staff safety. Second of all, we have centralized all our routine testing and samples on the track with the go live of the MMETH in September 2020, which allowed us also to increase our efficiency. Third thing, our Ministry of Health, Lebanese Ministry of Health, has set a new guidelines requesting us to handle all COVID-19 patients and under the hood and in a closed system, and to centrifuge them in a separate centrifuge. the ministry has exempted us from this task because we already have a closed system that is able to handle all the specimen from the loading, from centrifugation till the uploading closely, thus ensuring the safety of our employees. So we do consider all our samples received in the lab as infectious, so we will not be differentiating COVID-19 patients compared to non-COVID-19 patients.
Thank you so much, Rouba, and I want to thank you for your presentation today. Did you have any final comments for our audience before we go?
Okay. Yes, Bridge, I would like to highlight one more thing, one important thing, that what I have learned from this project and still learning, that it is operational excellence cannot be done unless it is with a multidisciplinary team, and we need to look at it from a multidisciplinary approach. It's not always about quality. It should be quality, it should be safety, and it should be continuous thrive to reach certain satisfaction. And I'm pushing always my team to look for ways and initiatives of what we can do better and how we can integrate the lab to be with other healthcare institutions as well as with other healthcare partners, because the laboratory being the core lab of a hospital, it is also should be a progressive and provide insights to physicians and patients. So this is a road we started, and it's a road my administration has set, and I'm looking forward in order to achieve it in the future. Thank you all for listening, and thank you all for these wonderful questions.
And thank you again, Rouba, for your time today and for your important research. And I want to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, stay safe and stay healthy. Take care, everyone. Bye-bye.